I'm excited about today's episode. We're focusing on a very timely topic, and that's Alpha-2 agonists, adulterants, the unregulated fentanyl supply. Specifically, we're talking about Xylazine and, more importantly, Medetomidine. This is timely for British Columbia because we've recently had several pockets of higher than expected drug poisoning or drug overdose events here in British Columbia, and we believe that that's likely associated with Medetomidine contamination of the fentanyl supply. So our guest today happens to be an expert in this area. We're talking about Dr. Jeanmarie Perrone. Dr. Perrone is an emergency room physician, also an addiction medicine physician. She is a professor of emergency medicine at the Hospital of the University of Pennsylvania. Dr. Perrone has published extensively in the field of opioid use disorder, specifically about buprenorphine induction strategies, and more recently around the adulterants that are found in the fentanyl supply. Well, thank you so much for accommodating us. I can imagine how busy you must be. I know we had a brief chance to talk. I think it was at ASAM, was it, last year?
Yes.
Yeah, and
that was great.
So that was nice. And I've been following your work for a number of years. I had the opportunity to work on a paper with you a few years ago, so that was fun. But thank you so much for joining us. Part of the purpose for this, we're doing a series of interviews, is just to really understand the landscape of opioid use across North America and sort of regional differences. I feel like sometimes we work in silos, and we may have something that works for us that others may not be aware of. But also, I think it's good to get ahead of some of the new emerging substances that are sort of coming on the scene. And you are one of the national experts in that area. So this is a
only by default, because we're seeing these emerging substances in Philadelphia,
which in of itself is super interesting to me.
Medetomidine,
right?
It is. Yeah. You should move to Philadelphia.
Well,
we could use some more local expertise sorting through it.
Well, it's coming here now as well. So we're starting to see it. We've always had sprinklings of it, but now it's sort of hit us pretty hard a few weeks ago. So hence really this sense of urgency to get you on the podcast. But let's take a quick step back, and just for people who might be listening who may not have a lot of the context. So fentanyl came on the scene, in Vancouver about 2012, 2013, completely changed the game. We're talking about almost overnight. We went from heroin, which was a typical opioid used illicitly, to fentanyl, which is 100 times more powerful than morphine, maybe 50 times more powerful than heroin. And the overdose epidemic crisis, drug poisoning crisis, whatever you want to call it, followed fentanyl. And the more fentanyl there was, the more people were dying. So we saw this pattern change, and I suspect you guys saw the same thing, where it was people first were using heroin, then they were using heroin laced with fentanyl, and they weren't actually aware that there was fentanyl in their heroin. And then all they could find was heroin that was laced with fentanyl. Then very rapidly, heroin was no longer available. So people were using fentanyl. They didn't want to be using fentanyl necessarily. That's just all that was available. And then I started to have a whole cohort of patients who had never used heroin before. All they've known is fentanyl. Is that the similar pattern that you guys saw as well?
Yeah, I think our timeline might be a little skewed. I would say we had episodic fentanyl between 2012 and 2016, and then more regularly between 2016 and 2020. Right around the pandemic, heroin disappeared completely. And then within about 18 months, there was talk of Xylazine. It was being detected. People on the street were telling us that their, trank was worse, withdrawal was worse. We started having trouble initiating people on buprenorphine. Maybe now for some retrospective different reasons, but at the time, it was difficult to sort out. And then obviously Xylazine with both a withdrawal syndrome and wounds, and that we sort of tried to meet people where they were in that era for about 3 years. Wow, creating walk-in clinics for wound care and a lot of things related to the challenges that xylazine brought, and now shifting again for medetomidine.
Right. And just to define some terms for people who may not be aware. So, we're talking about initially opioids. Heroin is a type of opioid. Fentanyl is a powerful synthetic opioid. And then once fentanyl came on board, we started to see fentanyl analogs, like we started to see carfentanil, which is an order of magnitude more powerful than fentanyl. Fentanyl, and again, this is just for the audience who may not be aware. Fentanyl is problematic for many reasons. One is because of its lipophilic or oily nature, it goes into the CNS very quickly, and it binds onto the mu receptors in a way that it outcompetes other opioids, and it stays on the receptors. But its actual half-life is quite short, so you have something that goes into the brain very quickly, is strong, starts to work very quickly, but then comes off. And that's sort of the highly addictive nature of it. But because it's so strong, it reduces your ability to breathe very quickly, and that's an overdose. And then because it's much shorter acting than heroin was, people needed to use much more frequently. Because of that, people who were manufacturing illicit fentanyl started putting additives in fentanyl to give it legs or make it last longer. So we started to have benzodiazepines mixed into the fentanyl, and then we started to see other additives like the xylazine and medetomidines as well, which are also sedating in of themselves. And there was also nitazines right before the xylazines and medetomidines, which is a whole class of synthetic opioids in of itself. So I guess the big picture is there's been this attempt by people who manufacture illicit fentanyl to add things to it to make it more sedating, to make it last longer, etc. And that's, I think, some of the reason why we started to see the emergence of these substances. And it sounds like where you are, you have a lot more experience with the xylazine, medetomidine than most places in North America because it hit you guys hardest and earliest.
Yeah. Just to comment on your reporting there. When I was a toxicology fellow at NYU Bellevue, we had heroin, and we had a little epidemic of patients who presented with anticholinergic poisoning, so tachycardia, dilated pupils, delirium, in the setting of also using opioids, and you wouldn't really discover it until you gave them naloxone for their opioid intoxication, and then they would develop this anticholinergic syndrome. And it was because they had put scopolamine in the heroin. So this was written up in the MMWR and, in this era. So there's always been adulteration of all of illicit drugs. For many different reasons, sometimes just bulking, and we would call that, something different, but adulteration specifically that, trying to get an additional effect to be psychoactive has a long history, and we've been responding to it. We just respond to it differently now because we have drug checking. So we know it's there even before we know that people are having symptoms. So it's hard to triangulate. Drug checking provides a lot of data. That some of it is very noisy because I don't know how different it is when somebody takes one fentanyl analog versus another fentanyl analog. But I do know when they take fentanyl versus, fentanyl plus medetomidine because different symptoms occur. And of course, the response to naloxone has shifted. So it's very interesting to see the clinical side correlated with the drug checking because you can't take either in isolation.
Got you.
If you just look at the clinical side, you're just hypothesizing about why is this patient still sleepy after Narcan? Is it benzodiazepine? Is it methamphetamine use and no sleep? Is it, medetomidine or xylazine? So it's interesting, but we have to put those two data streams together, which is almost impossible to do at the bedside. And that's what I think we need. Right.
No, exactly. Like in the sense that practically speaking, if a patient walks through the door, we don't have a rapid way of knowing what's in their system right now. So we have to just go based on our clinical gestalt. Right. So having said that, it might be interesting if you could describe what a typical patient encounter might be like for somebody that you guys might see walk through or be brought into the emergency department. and how this, who was maybe overdosed on illicit opioid or fentanyl, and what that clinical syndrome may look like.
Mm-hmm.
Yeah.
Sure. So around April of 2024, we had sort of a cluster of overdoses that looked different to very experienced emergency physicians, toxicologists. They were patients who were being brought in after receiving Narcan. They were persistently somnolent. And particularly in this case, the hallmark was bradycardia, sometimes hypotension, that lasted for many hours. Now, we've seen bradycardia with patients who take clonidine from the street, or bradycardia associated with methadone. But this looked different to the, kind of expert clinician emergency physicians involved. They reported it to health departments. Samples were taken. In general, it was about 12 patients at one of our hospitals right in the center of the busiest area for substance use. And with some delay, a couple months, ultimately it was confirmed to be medetomidine. Before we had the drug confirmation in the people, the biospecimens that were sent to a lab, we had local drug checking data that also said there's some medetomidine in the drug supply now. So connecting that as the smoking gun took many months of confirmation, but ultimately it fit a new clinical picture, and it fit the fact that this had emerged in our drug supply. Now, fast forward, that's April 24. By fall of 24, we started seeing really profound patients who would come to the emergency department, that same scenario, possibly bradycardia, maybe persistent lethargy. And then within 3 or 4 hours of their arrival, they would say, I'm starting to feel sick, or they would just come in saying, I feel sick, I have withdrawal all the time, I have to use all the time. And I get much sicker now from withdrawal than I've ever have before. And until you really see it happen to somebody, it's hard for clinicians to see that this is something different. But having been at the bedside, the patients, you talk to them in the beginning and they're like, I just need some help. And they have normal vital signs and they look okay. And then about 3 hours later, you get asked to, you give them some methadone, you give them something, we're going to send you to a detox or whatever you want, offer them buprenorphine, et cetera. But within a couple of hours, while they're waiting to be transferred somewhere else, all of a sudden their heart rate gets fast, they start to vomit, they develop diaphoresis, sort of a CALS of 20 to 30, however you want to describe that, all the sickness of an acutely elevated opioid withdrawal syndrome, accompanied by very profound hypertension and tachycardia. So, heart rates of 140 to 160, blood pressures of 240 over 130.
Interesting. Okay.
So really profound. So if you had to describe it, you'd say it was a mixture of alcohol withdrawal or benzo withdrawal and opioid withdrawal, because they still have the opioid withdrawal symptoms. Now, we've learned to be really aggressive about opioid withdrawal, and we give people very large quantities of full opioid agonists. So we can quiet down the opioid withdrawal. Despite that, these patients would have these vital sign abnormalities, and they'd be writhing. It looked like precipitated withdrawal, maybe, just a very sick, very uncomfortable patient with extraordinarily abnormal vital signs. And as we were trying to figure out, again, what are the culprits in the drug supply that could be doing this? This is not xylazine withdrawal. We've been dealing with xylazine for 4 years, and we've never seen anyone get this sick. And then it was all of us at these 3 or 4 hospitals, academic medical centers, where we started talking regularly. And we started treating with people with dexmedetomidine. First, we intubated a bunch of them because they were just too sick to manage. And then just got, high dose everything sedative. We did find that benzodiazepines, which would have been your first, arm of this looks like a mixed alcohol opioid withdrawal syndrome, were not really working. They were really making the patients more encephalopathic, more delirious, but not actually helping with the sedation. And then we started using dexmedetomidine, at least in a large proportion of them initially, who needed to be intubated. And then we started treating people without intubating them and just giving them dexmedetomidine. And, of course, lots of clonidine. And that seems to be the treatment that makes the most sense. We also went to the literature and found, dexmedetomidine dependence had been described in pediatric patients who got dex for sedation. And a lot of the parameters about how long you can use dexmedetomidine comes from the idea that there's a withdrawal syndrome once you develop dependence. And so dexmedetomidine withdrawal kind of looks like, obviously looks like what we're seeing, except it's a more minor syndrome than I think what we're seeing, because we're seeing people who are getting massive doses of medetomidine on the street, developing a dependence, and then having this short cycle between dependence and use and withdrawal, and then coming in and having these fulminant abstinence syndromes that seem to be only treatable with dexmedetomidine.
Got you. Okay, so
right now, current state, 25% of our ICUs in Philadelphia are filled with patients
25%.
with medetomidine withdrawal. 25%.
Wow.
So that's not great for a lot of reasons. And I'll also say that after a couple of days of being on dexmedetomidine, of course, we're trying to transition people to buprenorphine or methadone or something. And we have a much higher PDD rate, patient-directed discharge rate, than we previously did. And we think that a lot of that has to do with, a new craving syndrome. We're also seeing people getting really sick on Sublocade. So they're on Sublocade, they're still using because they're still having cravings. They're really probably having some degree of their cravings from medetomidine. They're going out and using, 10 or 12 bags a day. And you would think at 10 or 12 bags a day, they'd be at less of a risk of withdrawal than the 3 bundles a day patients. But everyone seems to be getting this if they're using regularly. And then the medetomidine, the patients who are on Sublocade, it doesn't seem to protect them from having this if they're using on top of it.
Got you. Okay.
So it's really problematic.
Right. Wow. I mean, okay, so there's a lot there. Let me try to...
Sorry.
No, this is fascinating. And it's important for me just to kind of try to tease out some of the details. So, and in fact, we should probably define what Xylazine and medetomidine are. So they're Alpha-2 agonists. And some medications that are used in veterinary medicine, essentially as sedatives, right? And we have some similar medications we use in humans, but, so we have clonidine, and then we have the much more powerful one, which is dexmedetomidine, which is used in the ICU setting, really, typically. So,
yes.
Right. Okay, so now the withdrawal syndrome that you're describing, so we have a patient come in, they have what we would expect from opioid withdrawal, right? So dilated pupils, diaphoresis, so sweating, runny nose, nausea, vomiting, diarrhea. So that happens. And based on that, we still don't know if this is just opioid withdrawal or if there's something else going on as well. And it sounds like what's differentiating it from pure opioid withdrawal is the tachycardia and the hypertension, so high heart rate and blood pressure,
and some altered mental status that I would say is more or less consistent with the combination of medication they might be getting, a little bit of clonidine that we give them. It's not an agitated delirium as much as there's a lot of discomfort associated with kind of all of their symptoms. And I would say everything you just said about opioid withdrawal, we primarily see patients with medetomidine withdrawal who have not yet developed opioid withdrawal. So this happens before they have all of
And how do you distinguish that then? The medetomidine withdrawal is
like you said, they don't get, they get, maybe day, if they're not aggressively treated for opioid withdrawal, maybe, 10 hours in, they have a lot of opioid withdrawal. But this is happening, the same patient who comes in too sedated from just using and waiting in our waiting room, within a couple of hours goes from, comfortable and sedated to this flipped switch within, say 3 hours. And they haven't developed fulminant opioid withdrawal yet, but they have this other phenomenon that's happening earlier.
Got it. Okay. Sounds like...
So less of the cows, less of the dilated pupils. They might have dilated pupils because of the sympathomimetic effects of what we think are going on, but they don't have the rhinorrhea. They don't have the goose flesh. They don't have some of those more objective signs of opioid withdrawal that tend to happen a little bit later. They do have a lot of vomiting.
Interesting.
But we think that's more or less dexmedetomidine, but they don't have diarrhea, for example.
Interesting. Okay, so that the timeline is interesting as well. So that could be an interesting clinical tool that they come in. You see and what about the benzodiazepine or alcohol withdrawal type symptoms? So primarily, what I would use is tremors to distinguish. Are they experiencing tremors at all in this setting as well?
Yeah, that's such a good question. They do have various kinds of tremors. Sometimes they have kind of whole body shaking with jaw shaking.
Yeah.
I would say it looks different than the tremors associated with alcohol withdrawal. Some people have described it as, almost serotonergic, like wet dog shaking tremors, more total body than what you see with alcohol withdrawal.
Okay. Yeah. Okay. So, hearing you describe this, I can say for certainty that I've seen this withdrawal syndrome now. And it's interesting. It's almost like the whole body is shaking, but you don't have like this sort of the fine tremors, tongue fasciculations that you might see, or the coarse tremors, tongue fasciculations you might see in benzodiazepine or alcohol withdrawal. But it's sort of like whole body shaking, which is different. And the delirium. Okay, yeah. So a patient comes in, they have this syndrome, their urine drug screen. The ones that we do test for benzodiazepines and opioids, but they don't test for medetomidine. I'm guessing you guys don't at the bedside test for medetomidine, but based on the clinical scenario,
we have,
yeah. So it's basically a clinical diagnosis at this point. And
that's right.
Okay, so clearly a patient is in medetomidine withdrawal. What do you do next? So
we have a lot of things. We've made a lot of recipes, and we're doing our best to keep up with what might be working. The first thing we like to advise is that even when the patient looks well, get some clonidine into them, because what really becomes rate limiting is the vital sign abnormalities that and the vomiting. So if you can't turn off the vomiting, you can't give them enough clonidine to keep their vital signs, to basically replace the alpha agonist. If we could have IV clonidine, that might work. But right now we're limited to, IV Dexmed is the only way we can get an Alpha-2 agonist into them if the vomiting kind of beats us to, in that window. We've also had problems with, giving people high dose clonidine and then they get hypotensive because we can't really predict who is really going to have the fulminant syndrome. So it's a little bit of a guessing game. So we have a clonidine escalation protocol while they can take oral. We have poly full agonists, oral oxycodone, oral methadone. If they can't take it orally, IV Dilaudid, IV methadone. So lots of opioid agonists, ketamine, either oral or IV, a host of antiemetics, a little droperidol,
Gotcha.
And then ultimately, if all of that is failing, dexmedetomidine in the ICU. And we're really putting a lot of thought into how to keep people out of the ICU. Sometimes, a patient goes to the floor, they get sick, they need ICU escalation. Oh, but there is no ICU bed. So then we end up managing patients on the floor. And some of them, if you can get the vomiting turned off and you can get them back to being able to take oral clonidine, you can avoid that sort of junction and need for dexmedetomidine. But we haven't quite figured out the exact cocktail. And obviously every single patient is different, so we're titrating.
Yeah. What does your clonidine protocol look like? So
it's 0.2 milligrams if your blood pressure is, I think, less than 110, but greater than 100. So, 100 to maybe 120 we wrote. If they tolerate that for one dose and they continue within a couple hours to still have at least 110, you can repeat the 0.2. If it's between, I don't know what we said, 110 to 130, they can get 0.4, greater than 130, they can get 0.4 twice, and then it continues to go up from there. Obviously, people with higher blood pressures can get 0.6, and then whatever they tolerated with continued blood pressure titration, we will continue to escalate the clonidine.
Okay, and do you have this published?
No, these are like just going into effect order sets. I have to say, there's a lot of good energy and like monthly, weekly feedback about what works across all of our hospitals. And yet to actually implement the order sets, the changes in the EMR takes so much longer than our ability to say, let's try this. So we are working on it. But, in the COVID era, when we rapidly iterated every day, it's hard to escalate this to a crisis level as much as it needs to be for our patient population.
Yeah, no, I get that. Explain to me where the need for intubation comes from. Is that as a result of patients being on dexmedetomidine now? You start them on infusion and then, or is that? I don't imagine it's part of the withdrawal syndrome in of itself.
No, there's no respiratory depression associated with the withdrawal syndrome. What I would say that our intubation rate has probably gone down a lot because in the beginning it was more just a control this massively agitated patient that we don't know what's going on. In the beginning, I would say a few of these patients would have been called precipitated withdrawal. Maybe they got buprenorphine somewhere in their scenario and somebody said this is precipitated withdrawal. They're, really sick, et cetera. And just kind of as a throw everything at them, they'd get intubated. The other thing is, as they get sicker, they tend to lose IV access. I can tell you about a patient I took care of a couple, weeks ago that sort of flipped the switch on me while we knew she was at risk, but she looked so good in the beginning, et cetera. And then as she got the most sick, she was losing her IV access and somebody who doesn't have great IV access. So the delays associated with managing the agitation, maintaining IV access, sometimes intubation is the answer. But I would say our overall intubation rate has gone down as we've started Dexmed earlier. That's basically it. The other thing we've done is we've gone up on the max dose of Dexmed because, what we were limited to by hospital protocol was not enough.
So what are the doses you guys use?
Sense.
Yeah.
So I think our max before was, I want to say 2, and we went up to 2.5 micrograms per kilogram per hour. I could check that, but it might have been 2.1 was the max, and we went to 2.4. We also just started doing boluses, which we were not allowed to do before because, I think they can use boluses in the ICUs and in the OR, but our formulary only allows for and it was like half an hour between increasing the infusion rates. So we also had to decrease the time between escalation of the infusion rates because you need rapid control, or again, you lose IV access and then you're, back to square one.
Okay. But just to be clear, dexmedetomidine is only used in the ICU setting for you guys. Is that right?
The emergency department and the ICU.
Yeah. Emergent ICU. Okay. And what about the difference between xylazine and medetomidine withdrawal? Is it just medetomidine is a more severe version of xylazine, both being alpha-2 agonists, or?
So xylazine was really clinically silent, I think, for years and years and years until it became a higher concentration present and maybe more prevalent in, X number of bags. So maybe 90% of the bags had xylazine, so you were always getting xylazine. And I think that chronicity gradually contributed to the formation of wounds, just epidemiologically. We still don't know why wounds occurred. But what happened after that was, patients said that the xylazine withdrawal was worse than the fentanyl withdrawal. And I'm not sure that was ever true, but patients would get really anxious and really dysphoric early on in their hospitalization, and this or early on in their ED visit. And this was when I was doing the clinical trial of buprenorphine initiation in the ED. And so we were really trying to keep people in the ED long enough to get sick enough to be ready for a dose of bup. And a lot of them were just like too restless, too anxious. They did not have these vital sign abnormalities. They did not have, this level of agitation. But I think what the patients felt was something that was a withdrawal syndrome. It was just relatively mild. We did a big chart review that we did publish. Ashish Thakkar is the first author, I believe, looking at xylazine withdrawal syndrome. Is there a xylazine withdrawal syndrome? And we meticulously reviewed a lot of charts. We never saw the signals of vital sign abnormalities or anything that looked like a prominent syndrome. This medetomidine is over 10 times more potent than xylazine. And I think just the use and exposure has created a whole nother dependent syndrome that's much more obvious and much more potent.
Got you.
The drug's more potent, the withdrawal is worse.
Do you see the same wounds with medetomidine?
So that's such a good question. Maybe there's a little light at the end of the tunnel. We're seeing a definite decrease in wounds. I'd like to optimistically maybe think that it's related to medetomidine, but I think it also might be related to a lot of harm reduction education where people were not using IV, even decreasing their intranasal use and shifting to smoking, which seemed to mitigate some of the wound development. So all those things happen at the same time. Hard to say for sure that it's not.
And since we're on this topic of wounds, how would you differentiate I feel like almost all of my patients have some element of cellulitis, particularly in their legs when they're living rough. But how do you distinguish your typical cellulitis with a Xylazine wound?
That's a great question. I could show you with pictures, but I'd say there's a lot more ulceration. They're not abscesses, they're not cellulitis. In many cases, they're almost like a sterile ulceration, at least initially. It starts with a small ulcer either at the site of injection or definitely remotely from injection sites. They tended to be more on the extremities if not associated with an injection site. And that ulceration would just kind of get bigger gradually. It might meet up with another ulceration and form a larger, skin deficit, and then there would be depth to it over time. People did inject into their wounds for comfort, and that certainly didn't help. But rarely, and people do get osteomyelitis and deeper soft tissue infections. But with a lot of the walk-in wound care that people have access to, the ulcers are happening, the deep infections are happening, but the superficial wounds don't look like a cellulitis or an abscess. They're really more sterile than that.
And are they,
uninfected?
And are they always associated with injection use?
No, they've definitely been associated with intranasal use.
But always on the extremities.
I'd say anecdotally, I mean, if you inject in your neck, you would get a big ulcer in your neck. I'd say primarily the extremities, except they could also occur at injection sites that might have been
right. But let's just say somebody smokes only. Would they still be getting ulcers in their extremities and other parts of their bodies?
I think they can. I think we all think that it was associated with smoking too. A lot of people who smoke also use multiple, at least in our historical cohorts. The people who are smoking now previously used IV and or intranasal at least. So there was some of that already, kind of in exposure. I think for maybe a younger generation or a different generation or a West Coast patient only using smoking, maybe they wouldn't get wounds.
Interesting.
But I think it's a little bit of a mixed picture now.
Right. That's what I'm trying to differentiate. We're getting off topic a little bit, but because like you said, in West Coast, Vancouver, California, there's been a shift over the past several years to smoking only. So I guess the thought is there something vasoconstriction, whatever it might be, associated with xylazine that may result in extremity wounds in the absence of injection, or is it typically as a result of the injection that the wounds would occur? Maybe we don't have a good answer to that.
I don't think we have a good answer. I think it's definitely more associated with injection practices, injection or intranasal practices. But again, in our communities, people who smoke previously generally were also using it by other routes. We don't have a lot of native smokers, I guess.
Got you. Okay, and the, with regards to treating the withdrawal when patients come in, what kind of doses of opioids do you guys typically use? And like, do you have the typical protocol that you might use for managing these patients?
I can refer you to our website where we have a lot of these protocols listed. I mean, we start with 40 to 60 of methadone, usually one dose of 40. Then we can go up by 10 or 10 again in a couple hours. Then we use oxycodone, 20 to 40 Q2 that, can escalate rapidly. And then, for more breakthrough, we have IV Dilaudid, we have PCAs. I can't tell you in MMEs, but I would say that we use a lot of opioids. And we actually have a big opioid shortage now, which I think is going to be
interesting,
extra challenging.
So it sounds like we're quite clear. This isn't untreated. Just to be clear for the audience, this is not untreated opioid withdrawal. This is a completely different syndrome.
I think that's an important point. And I definitely think that there is a lot of art and science to seeing that at the bedside as two different things that I think more of a clinician needs to tell you, because the patients have trouble separating out the symptoms. But I do think that, when you look at somebody who has very objective opioid withdrawal symptoms, they look a little different. And I think we basically blanket people with opioids, and then we add this on. And then, within a few hours that might go away and they need more opioids, obviously. So we're always looking at the sort of threading the needle between those two syndromes, while also trying not to neither over-sedate nor, create a big challenge of peeling these medicines off on the other side when we're trying to get people out of the ICU.
Got you. Okay, and then let's take one quick step back. In the field, if somebody overdoses or has a drug poisoning episode, with opioids, we typically give naloxone, also called Narcan. Now, anecdotally, what we're hearing is that Narcan is less effective in patients who are also using medetomidine.
I would reword that a little bit.
Please.
I would say naloxone is highly effective in patients who are using fentanyl and medetomidine to reverse the fentanyl, which is all you could ever expect it to do. So it restores respirations. However, the somnolence and the persistent lethargy and perhaps the bradycardia may be more apparent, after that. We previously, and probably in Vancouver too, the EMS gives a lot of naloxone. Most patients then walk away, right? They don't want to come to the hospital. They know what they need, or they know what they're ready for. We don't, now people can't walk away. So we've had so many more ED visits for overdose. And these were overdoses that didn't tend to come to the hospital. And again, those are the same patients who sometimes, if they stick around long enough, develop medetomidine withdrawal after an overdose visit, or during an overdose visit. So that transition is very quick. But the naloxone does work. I think it also is easy to say that higher doses aren't going to help, right? So, but people think that, they're not responding because they haven't woken up. So they're getting higher doses.
Right.
But it doesn't mean that we need higher doses. It just means that our endpoints have not been socialized, that this patient's respiratory rate is better. It's hard. You don't have a pulse ox and you don't have someone on a monitor. It's easy to see a patient who's, unresponsive continues to be unresponsive and is at jeopardy of stopping breathing, even though they've started to breathe a little bit. So I think we have to re-educate about clinical endpoints that matter in out-of-hospital resuscitations.
That's a good point, because you could, in some respect, if you keep giving naloxone, you could make sort of medium-term management of this patient even more difficult, because now you have this persistent opioid withdrawal plus medetomidine withdrawal, and the opioid withdrawal is becoming more difficult to treat because they have a ton of naloxone on board. Yeah.
Yes.
Yeah.
Yes. Yeah. That's true.
Okay. Okay. So Xylazine, medetomidine. What do you think the sort of the end game here is? Do you clearly?
It's a great question.
Yeah. Please.
We need to learn to be more COVID responsive, because we think that Xylazine may have been this switch might have occurred because Xylazine was actually scheduled around April or May of 2024, and there was a lot of press that this was going to happen. So there might have been a preemptive switch from Xylazine to medetomidine in the response that there was going to be limited supplies of Xylazine, if it was in fact being diverted from internal sources. A lot of people said it was being ordered from websites and imported from China, et cetera. So I'm not sure what the sources of Xylazine were, but locally, when it was scheduled, it correlated with this switch from Xylazine to medetomidine. So there is another bill in front of and that was only statewide. That was only in Pennsylvania. Unlike other drug epidemics, things tend to affect the Northeast, sort of it hits Baltimore, it hits Philadelphia, and then it radiates to New York and New England. And yet this has really been staying pretty localized to Pennsylvania, and what's interesting is Pittsburgh, which is another city in Pennsylvania, is about 6 hours from Philadelphia. So it's not right next door. And they are one of the other epicenters of having a lot of problems with medetomidine. So we're in close contact with them, as well as people in the middle of Pennsylvania who are having problems. Also Delaware, which is about half an hour from central Philadelphia, and Camden, New Jersey, which is also about 15 minutes from central Philadelphia. So all of those areas are seeing the same drug supply and the same problem, but it seems more related to the fact that locally in Pennsylvania we had this Xylazine sort of increased scrutiny, and now we've shifted. So what will happen next? We're going to legislate medetomidine potentially. We're going to shift to something else. We need to be, learn to be fluid and iterative and rapidly respond to these blips, correlating drug checking with bedside exposure and being able to literally kind of test on the spot, what is effective, and then being able to rapidly disseminate that. So I appreciate the opportunity to come on here and tell you what we're seeing. I'd love to hear about your patient, but we might have to take a rain check on that I have to hop on to another meeting.
Well, this has been fascinating. So thank you so much for your time. I've learned a ton. I would love to get you back on here. I feel like there's so much more I could learn from you. So I would love to send another invite at some point to have you back on.
Sure. Sorry, this was just quick. So
it's okay.
Laying the groundwork.
Absolutely, 100%.
But great to talk to you, Pouya. Thanks for your team.
Okay, thank you.
All right. Take care. Bye-bye.